मास्क हटा दो। Good morning, everybody. Hardik, Lohitashwa, can you hear me?
Yes, sir. Yes, sir. You are audible.
So good. We'll wait for a few more minutes. 11 people have joined.
Yes,
How,
sir. Like
how many?
three or four.
How many were expected?
Sir, it's like revision class. So those who have doubt, only 15, 20 people said me that they have doubt in interstitial lung disease.
Okay, 20 members.
Yeah.
Okay.
Around 15.
Fine. इसमें कुछ लॉगिन का प्रॉब्लम आ रहा था। रूम से मैं ट्राई कर रहा था, ट्राई नहीं हो रहा था। देन आई केम बैक हियर। दैट्स so it's 8:05. We'll just instead of sitting quietly, we'll just have a formal discussion. So amongst who have joined online, do you have any? Have you all went through about the lung diseases, interstitial lung diseases in the textbooks? All of you can unmute yourself. You are unmute. We'll start discussion. So let them join. Whosoever wants to join later. Shall I call one by one? Let's have, because we have only 13 members online, students. Huh? On. Huh? It's on. Speakers on. Hardik, let's start with you only. So what queries you have in interstitial lung diseases? Hardik, you are online. Can you hear me? Lohitashwa, Sean, Dora, anyone?
Where is Bhavik Bansal?
Bansal?
Bhavik Bansal has not come. He wanted all these classes.
He has not joined today.
Mm-hmm.
Excuse me, sir.
Acha, please identify yourself.
Sir, I am Ebin Anthony.
Okay, fine. And did it tell me, so where you felt difficulty, what you want to know in interstitial lung diseases?
Sir, my doubts are mostly on how to differentiate between different types, sir.
Okay, that's fine. Do you know the classification of and all of us, I think we have 13. You want me to take a few minutes regarding the overall features of interstitial lung disease, later on we'll discuss, or you want me to discuss like this?
Sir, I would say if you could take a 5 minutes for just the basic overlay
Okay.
first,
It will take 10
it
to
would be
15
helpful.
minutes so that I can overall I can tell you what exactly the interstitial lung diseases are, how to differentiate them, why we need to categorize separately. So those highlight few important points in 10 to 15 minutes. I will just rebrush it. Later on, if your queries are not solved, then we'll have a discussions. Is it okay from all of you?
Yes, sir.
Yes, sir.
Yes.
Yes, sir.
Yes.
We'll take 10 to 15 minutes. I'll just go through all the slides. You just concentrate. I'm not going to go in detail regarding each and every line, but I will tell you the main important points. Right? These interstitial lung diseases, it is a big chapter, a separate group of lung diseases when compared to other diseases. Why they have clubbed separately is mainly because they are on respiratory physiology. So whenever you have a lung involvement, depending on the respiratory physiology, you will divide the lung diseases as obstructive lung diseases and restrictive lung diseases. You know this, all of you? I need more of an
Yes, sir.
interaction for each and every line. I want some interaction from you people. Okay, they are classified as diffuse parenchymal lung diseases. Okay, it is not localized to single lobe or two lobe or right lung, left lung. These are diffuse, the uniform almost. It involves both the lungs, most of the lobes. So it is a uniform involvement, diffuse involvement of lung diseases. That's why they have clubbed together. These diseases predominantly involves the lung, right? The other system involvement usually not seen. So it is the diseases which are particularly seen in lung parenchyma, depending on, so you know the histology and you know the anatomy. If you see the lung parenchyma is divided into two types. One is a conducting system where it mainly contains tracheobronchial tree. The main function is to conduct the air. Diffusion will not take place. Do you is it fine with you? Is it clear?
Yes, sir.
Tracheobronchial
Yes, sir.
tree, tracheobronchial tree is mainly for diffusion, conduction of air from the nose to the lung parenchyma till the respiratory bronchioles and alveoli. That is one part. So any obstruction in this conducting system, we label it as obstructive lung diseases. There are certain groups of diseases on respiratory physiology. They show obstruction physiology. I will tell you those respiratory physiology in next few lines. And after this, the terminal respiratory bronchiole and the alveoli, these are the lung parenchyma where actually the diffusion takes place. You will see the lung elastic tissues present in the alveolar component. The main function of the alveoli is to expand and collapse so that air, when you inhale, the alveoli will expand. So when you exhale, alveoli will collapse. The main vital capacity of the lung depends on the elastic recoility of the alveoli. All of you agree?
Yes, sir.
Yes. So now I'll talk two lines about respiratory physiology. The spirometric analysis. So when you have a lung problem, when you go to respiratory physician, first thing they will do is see respiratory. They do spirometric analysis. When you have a pulmonary posting, you observe all those things. So in spirometry, they have two important values they'll observe. One is force expiratory volume in 1 second. That is a percentage of volume that you can express or exhale in 1 second. That is called forced expiratory volume. The percentage of air that is exhaled, one Y value, and vital capacity of the lung. That is two things. Depending on the value you get after spirometric observations, you divide the lung diseases into obstructive lung diseases and restrictive lung diseases. I'll come to restrictive lung diseases where the main important component is interstitial lung diseases. Let's see. Forced expiratory volume in 1 second means the air has to come to the conducting system and expire out. All of you agree?
Yeah, right.
Right.
Yes, sir.
Okay. So whenever there is obstruction anywhere in the conducting system, what will happen to forced expiratory volume in 1 second?
It will decrease because the
Obviously
expiration
decreases.
is
So
not fast.
when the pulmonary physician, and what will happen to the lung capacity, the vital capacity of the lung, if there is obstruction?
It's increased because more of the
It may be normal
gas.
or it may be mildly increased. All of you agree? So when the respiratory physician, pulmonologist will see that there is forced expiratory volume in 1 second is decreased with normal vital capacity or mildly increased vital capacity of the lung, he categorizes the lung diseases as obstructive lung diseases. Let's see. In the normal physiology, the main elastic recoility is present in the lung alveoli. Any disease which affects the lung alveoli or respiratory bronchioles, or any diseases which affects the rib cage or the pleura, I mean to say, this lung expansion and collapse, it not only depends on the lung parenchyma, it also has a effect from a function from the thoracic cavity. All of you agree?
Yeah.
Fine. So any diseases
Yes,
of the
sir.
any diseases of the thorax, any immobility of the thorax, or any diseases, diffuse diseases affecting the normal lung elastic recoility, it will lead to restrictive movement of the lung. All of you agree?
Yes, sir.
Right? Right? I want yes or no. Anyone?
Yes, sir.
Yes, good.
Yes,
So,
sir.
yes. So when you do respiratory physiology in these patients, what will happen? The forced expiratory volume in 1 second, what will be the value? Is it normal, increased, or decreased?
Decrease to normal.
It will be normal. Okay, forced. So when you inhale forcibly, you how much percentage of air you exhale in 1 second, it will be almost normal because conducting system is all fine. But when it comes to vital capacity, because the elastic recoility is lost, the vital capacity of the lung will be decreased in these patients. The FEV, vital capacity, vital volume, lung volume will be decreased. All of you agree? So the most important thing, you need to take ratio of forced expiratory volume in 1 second divided by lung volume, functional volume of the lung, FEV. So when you see this ratio, it will be increased in restrictive lung diseases. It will be decreased in obstructive lung diseases. Okay. So now after lung physiology, you know that there is a restriction in the lung. Next question comes, where is the restriction? Whether it is in the pleural diseases, thick adhesion pleura which is restricting the movement, or it is immobility of the chest, rib cage, or it is in the lung parenchyma. So you have to exclude one by one. If you say the rib cage is normal, all the muscles are normal, the pleura is normal, then the main problem lies is in the lung alveoli, that is in the diffusion part of the lung. Okay, so these are restrictive lung diseases. When you see restrictive lung diseases, one of the most important category, because why there are long subtype, subcategorization in restrictive lung diseases is mainly depending on the etiopathogenesis. Why they have clubbed together means all those diseases, some 5 to 10 diseases that I'm going to tell you now, they all show a respiratory physiology like restrictive physiology. They have a most common important for undergraduate level. When you see the biopsy, all those interstitial lung diseases, they show some kind of an inflammation which is predominantly involving the lung interstitium. Alveoli will be normal or less widely involved. That's why the category we call it as interstitial lung diseases. Why it happens when the disease becomes severe or progressive, that I will tell you. At this point of time, are you clear that all interstitial lung diseases, why they have clubbed together means they will show lung physiology spirometric, after spirometric analysis they show restrictive lung function, and on histopathology they show a predominant involvement of lung interstitium, that means the space, tiny space between the two alveolar walls. All of you agree?
Yeah.
Yes, sir.
Okay. So, and when you see the pathophysiology of all these interstitial lung diseases, almost same. If I want to see the broad, there is some known or unknown antigenic stimuli or injury causing the damage to the alveolar wall, leading to destruction of type 1 and type 2 alveolar site, leading to inflammatory cell recruitment, leading to release of lot of inflammatory cytokines, causing fibroblastic stimulation, ultimately in the end stage leading to fibroblast, the proliferation of fibrosis in the lung interstitium. This sequence of events is almost same in all the interstitial lung diseases. They have a common clinical presentation, they have a common respiratory physiology, they have almost a common, except for few things, they have common histological findings, and almost they have common pathophysiological process that is causing these interstitial lung diseases. All of you agree at this stage?
Yes, sir.
Yes, sir.
Okay, so if you see the classification of these depending on the observations on histopathology and depending on the known etiological factors, there are broad classification. What you should know is most important is the second one. So all of you can concentrate. These are called as idiopathic bar primary interstitial lung diseases. This is very important. The main motto of the clinician or the main motto of radiologist or the main motto of histopathology who is reporting the biopsy is to identify or to exclude whether the patient is idiopathic pulmonary interstitial lung diseases or not. The main motto is because the prognosis is totally different in idiopathic pulmonary interstitial lung diseases, and they have worse prognosis when compared to other interstitial lung diseases. So main idea of all these clinicians and histopathologists is to say whether the patient belongs to idiopathic interstitial lung diseases or not, or rest of all in other group, where you can identify the cause, you can treat, and the prognosis is good. All of you understood at this level?
Yes, sir.
Okay. In idiopathic
Yes, sir.
pulmonary in idiopathic pulmonary fibrosis, the most and the foremost interstitial lung disease which shows very bad prognosis occurs at the age of more in the fifth decade or more, and gradually progresses. Treatment is difficult. Ultimate sequelae is deposition of fibrosis, and only treatment of choice is lung transplant. Is the idiopathic pulmonary fibrosis. You have to identify whether the patient belongs to idiopathic pulmonary fibrosis or not. The main classification is that all are worried about whether the patient belongs to IPF or not. Rest is all different. Okay, so we'll talk about IPF because it is very important. Okay, in IPF, idiopathic pulmonary fibrosis, and one thing you should also remember, interstitial lung diseases while reading, while reporting is different, while taking lecture is also different, but when it comes to the diagnosis of any patient, all of you should remember that the diagnosis is not that much easy as we read and as we say. All interstitial lung diseases per se, you have to see the histopathology and you have to discuss with clinician, radiologist and pathologist. That means you need to have multidisciplinary approach for each and every case of interstitial lung diseases before you make a final diagnosis. All of you agree? In alone, either clinicians or radiologists or histopathologists cannot make a definitive diagnosis. It has to be a multidisciplinary approach. All of you agree at this stage?
Yes, sir.
Fine. So there are some classification, ATS and ERS 2001 consensus classification. On your left side, you can see the histological patterns. What histopathologists can do is, what kind of a pattern I am seeing on histopathology. There are different patterns. What are those? It is a usual interstitial pneumonia pattern, non-specific interstitial pneumonia pattern, organizing pneumonia pattern, respiratory bronchiolitis or BOOP-like pattern, discombative interstitial pneumonia pattern, or lymphoid interstitial pneumonia pattern. Our main duty is to say the clinician that I am seeing this kind of a histopathology, and when you discuss in whole with clinical, radiological and pathological diagnosis, you have a certain entities. If you see usual interstitial pneumonia pattern, what are these pattern? I will show some histopathology slides, then you will understand. If I see under microscopy, it is usual interstitial pneumonia pattern. After clinico-radiological and pathological discussion, our diagnosis will be idiopathic pulmonary fibrosis, or it is also known as cryptogenic fibrosing alveolitis. If it is non-specific interstitial pneumonia pattern, that means the histological features, the key histological features which has to be there to call it as usual interstitial pneumonia, they are not there. I am not observing those things in my histopathology slides. Then you club all those as non-specific interstitial pneumonia. Here, non-specific interstitial pneumonia, usually they call it as waste basket. That means it is not usual interstitial pneumonia. Rest, it can be anything. Then you are telling clinician that under microscopy, it is not usual interstitial pneumonia. It is non-specific type. Please try to evaluate, take detailed history, take detail other investigation modalities to identify the cause. If you identify the cause, you can treat the cause and prognosis is good and patient will respond. All of you agree? This is main idea of histopathologist. You have to guide the clinician. Next is organizing pneumonia, diffuse alveolar damage. This I will tell you in
Yes.
show. So let's find. I'm not going to go in detail about idiopathic pulmonary fibrosis, that all of you can read, and I will tell you how to identify this usual interstitial pneumonia. When the patient comes with restrictive physiology, clinician is suspecting interstitial lung diseases. The first thing what he does is to send the patient for HRCT, high resolution CT scan of the chest. The radiologist, the pulmonary radiologist will take a photo and HRCT scan, he will evaluate. See, can you see the observation here? On your HRCT scan, the fibrosis and variably sized cystic spaces, what we call it as honeycombing, and the gravate lacy area, what you're saying is called fibrosis. This fibrotic honeycomb like areas on HRCT scan, if you see the distribution, they are present predominantly at the septal aspects. Can you see my arrow? Septal and subpleural aspect. And this part of the lung parenchyma is uninvolved. If you see this kind of a pattern, it is the radiologist way will say it is usual interstitial pneumonia pattern. It favors idiopathic interstitial pneumonia or idiopathic pulmonary fibrosis or cryptogenic alveolitis, fibrosing alveolitis. So this typically, the whole of interstitial pneumonia is mainly based on typical pattern of changes that the lung parenchyma is involved. So point number one, on HRCT scan, if the lung shows predominant fibrosis, honeycomb-like architecture located in the subpleural aspect and also the interlobar aspect with uninvolved lung parenchyma. Can you see my arrow here? These are all uninvolved lung parenchyma. One small part of uninvolved lung parenchyma is here. Small part of uninvolved lung parenchyma is here. Patchy uninvolved lung parenchyma in the middle of the lesion. It all favors and the idiopathic pulmonary fibrosis, and the radiologist will say yes, it is a case of idiopathic pulmonary fibrosis. One thing also you should remember, if the clinician, if the any patient comes with 5th decade or 6th decade, clinicians thinks it respiratory, restrictive lung disease. If radiologist is very confident about the idiopathic pulmonary fibrosis with typical these radiological findings, no need to take biopsy in these patients. This all of you should remember. Biopsy should be taken whenever there is a discordant in clinical and radiological changes. Then only the biopsy will come. If there is clinically they are fine, radiologically also they are supporting the clinical diagnosis, biopsy is not required. For example, if the biopsy is done, what do you see in biopsy? I mentioned in my previous slide that you see usual interstitial pneumonia like pattern. So what are this? I'll show you. The similar expression, what you see on gross, these are the images which is taken from the net for better teaching, only for teaching purpose. Can you see what we saw in HRCT? We are seeing the similar picture on gross. Can you see the cystic like variable cyst like spaces? We call it as honeycomb like spaces. This is the interlobar septa and this is the pleural aspect. These changes present predominant in the subpleural aspect and also involving the intersepta. These are the uninvolved lung parenchyma in between. So on gross, it is typically depicting the IPF pattern. So on gross, it is
These is the same as traction bronchitis, which was written in the last slide.
Yes. So traction bronchiectasis, one thing you should remember, it is a one type of bronchiectasis. Wherever there is lung fibrosis, anywhere in the lung parenchyma adjacent to the terminal bronchioles or bronchi, the part of the bronchi will be pulled apart, mainly because of contractile function of the collagen. All of you agree? Not
pulled
only
apart
so,
as it
yes,
dilated in.
yeah. What happens when there is bronchi or bronchioles are pulled apart due to fibrosis of the adjacent area? What will happen? The clearing mechanisms will be impaired. The mucociliary clearing mechanisms will be impaired. The lumen will be enlarged. The mucus starts accumulating. So I told you in my class, whenever there is accumulation of mucus anywhere in the lung parenchyma, it acts like a culture media for the secondary bacterial overgrowth. So this secondary bacterial overgrowth occurs, causes host immune response will come, inflammatory cells will come, they further damages the bronchiectasis. So this is a bronchiectasis. The main cause is due to adjacent lung fibrosis. So we call it as traction bronchiectasis. You are perfectly right. Traction bronchiectasis can also be seen in this IPF pattern, but it is secondary. All of you agree? Yes?
Secondary to fibrosis.
Yes. It is not primary. Primary lung physiology is interstitial lung disease. Traction bronchiectasis, what you're seeing is the associated secondary changes that you're going to see. Right?
Yeah.
Okay.
Okay.
Okay. These two pictures you observe. So whenever the surgeon will take biopsy, almost for to identify one thing, again you should remember is for a better identification, better diagnosis, there are different types of biopsy techniques are available. For interstitial lung diseases, the recommended biopsy technique is VATS guided biopsy, video assisted thoracoscopic surgical lung biopsy. You have to take a big chunk of lung to see. Why we need to take big chunk? This one thing, two important factors or entities that all of you should remember is spatial heterogeneity and temporal heterogeneity. If you see these two in a biopsy, it favors the diagnosis of usual interstitial pneumonia. This is very important. So what are these? Spatial heterogeneity means in the first picture, slide A, when you see some part of the lung parenchyma, if you can see my arrow, it is showing a lot of fibrosis. Okay. And the lung parenchyma alveoli, which is adjacent to the fibrotic area, is perfectly normal. So there is a heterogeneity of pattern in uninvolved lung parenchyma lying between a fully fibrosed lung parenchyma. There is again fibrosis here. There is again patchy fibrosis here. I'll show you other pictures. And there is uninvolved lung parenchyma here. So when you see this kind of a morphology under microscopy, we call it as spatial heterogeneity. Agree? This observation seen in case of usual interstitial pneumonia or idiopathic pulmonary fibrosis. When compared to spatial heterogeneity, see the second picture. It is temporal heterogeneity. What does this temporal means? If you see or concentrate within the fibrotic area, some of the areas they show advanced fibrotic stage. Some of the areas they show initial fibrotic stage. Some of the areas will show chronic inflammation. That means within the lesion, affected lesion, you have different stages of involvement. So this we call it as temporal heterogeneity. That means the antigen is constantly causing some kind of a damage and it is continuous. So this temporal heterogeneity and spatial heterogeneity, these are the important histological features for the identification of usual interstitial pneumonia or idiopathic pulmonary fibrosis. And when you observe this initial fibrotic area, see, can you see my arrow here? This is young fibroblastic proliferation. All of you can see there is spindle shaped cells. This is the lung alveoli. These are the type 2 pneumocytes, which are these big cuboidal cells which is popping out into the alveolar lumen. And see this part. This is just like a plug consisting of this streamline like fish like appearance, fish group like appearance of spindle shaped fibroblastic cells which are in bundles. They are parallel to the long axis of alveolar lumen or the alveolar lining epithelium. They are parallel. So when you observe this kind of a morphology, it shows that there is, these are called as young fibroblastic proliferation. It indicates there is initial antigenic event and it is called as a fibroblastic plug. All of you understand? Yes?
Yes, sir.
Yes, sir.
These are very, very, very important to identify or to classify as idiopathic pulmonary fibrosis. All of you should know what is spatial heterogeneity and temporal heterogeneity. If you don't see these pictures under microscopy, then whole category will go at as non-specific interstitial pneumonia, right? This is because this is very important. You have to search for spatial and temporal heterogeneity. You have to search for fibroblastic plug, and if you observe, and your idea towards diagnosis is towards idiopathic pulmonary fibrosis. Okay, this is very important. This I will not say. Okay, fibroblastic plugs and all I've shown you. Okay, sometimes what will happen whenever there is the secondary features that all of you should know, depending on the extent of inflammation in the interstitium, depending on the extent of fibrosis. Whenever there is a fibrosis, all of you already know that the main diffusion takes place at the alveolar interstitium. Interstitium will have a very thin walled fenestrated capillaries and branches from the pulmonary artery. Whenever there is interstitial fibrosis, the surface area of capillaries, when you take the per square centimeter or per area of the lung, the capillary density will be lost because they will be damaged by the fibrosis. So what will happen? Gradually these patients will develop pulmonary hypertension, pulmonary vascular hypertension. So whenever you may see this thick walled blood vessels, which are the histological indicators of pulmonary arterial hypertension. This is again secondary changes due to primary pathology in the lung interstitium, that is fibrosis. That also secondary. And as you mentioned earlier, you do see traction bronchiectasis because there is constant irritation, damaging to the alveolar lining epithelium. You see the metaplastic changes. You may see the columnar metaplasia. You may, that is bronchial metaplasia. You may see squamous metaplasia. You may see mucinous metaplasia in the adjacent lining alveoli. So whenever there is metaplasia, all of you should remember it impairs the diffusion. Even whenever there is a lot of fibrosis in the interstitium causing interstitial widening, it causes diffusion, impairment in the diffusion capacity. So all of this you should know. And one thing also you should remember that for histopathologist it is usual interstitial pneumonia pattern. Okay, for when you have a complete clinico-radiological and pathological discussion, it will be idiopathic pulmonary fibrosis. But what I mentioned you, this fibroblastic pattern or usual interstitial pneumonia like pattern, they are not only limited to the IPF, they can be seen in many other diseases. For example, some drug-induced diseases, autoimmune diseases, and occupational lung diseases, they can be seen. That's why I told you in the initial lecture, each and every interstitial lung diseases has to be diagnosed by multidisciplinary approach. All of you agree? Fine. Next comes non-specific interstitial pneumonia. When do you say the patient will have restrictive physiology, and the clinicians, pulmonologists will send the patient for HRCT scan, see this HRCT scan. So when compared to previous idiopathic pulmonary fibrosis where there is dense fibrosis, here you see ground lac opacification. It is more of a diffuse. You don't see spatial heterogeneity on radiology. It is like more of a uniform. There is no uninvolved lung parenchyma in between the lesion. Whole of the lesion is almost like the stage of the lesion. It is almost uniform. Wherever you take biopsy, either it will be in initial stage where you see only inflammatory cells in the interstitium, or it will be in the later stage where you see fibrosis, or it may be inflammation and fibrosis, which is called as intermediate stage. So all the lesions will have an uniform stage of involvement. There is no uninvolved lung parenchyma. So when you observe this on HRCT, the radiologist will say it is not a case of IPF. I favor non-specific interstitial pneumonia pattern. Then the clinician or surgeon will take biopsy, and the biopsy, when it comes to you, you also say that it is not usual interstitial pneumonia pattern. That means there is no fibroblastic plugs, there is no temporal heterogeneity, there is no spatial heterogeneity. Then again, when you see this picture, can you see? If you observe the empty spaces, what you're seeing, these are all alveolar lumen. Some of the alveolar lumen, you can see alveolar macrophages. These are normal or mildly increased. But when you see this picture, all of you can definitely say that the predominant inflammation is limited to the interstitium. All of you agree?
Right.
Yeah?
Yes, sir. Right.
Yes. There is widening of the
Yes, sir.
interstitial space. There is widening of the interstitial space. All of you agree?
And hypercellularity.
Yes, there is hyper. That means it is in the initial space, phase. And when you see the whole slide, all the interstitium they have in the similar pattern. All the interstitium in my picture, they have all inflammatory cells. There is nothing else. They are uniformly involved. There is no uninvolved lung parenchyma in between. All of you agree with me?
Yes.
So this kind of a pattern, when you see, this will be clubbed towards non-specific interstitial pneumonia pattern. When you say non-specific, it is big relief for the patient. It is big relief for the clinicians to treat because the prognosis is good. You can prescribe steroids. You can identify the cause. They'll try to dig more etiological factors. They'll try to identify the cause. If you identify the cause, the patient will improve. His respiratory physiology will improve. Okay, but in IPF, it is big problem for the patient, bad prognosis, big problem for the clinicians to treat also. The ultimate end sequel is lung transplantation. That all of you should remember. This is the initial stage. When you, if you want to tell the clinician that it is in initial stage or in the late stage or in between intermediate stage, it is your duty. It is a duty of the histopathologist to say. With this picture, if I see under microscopy, I will say that it is the initial cellular phase, because I am seeing, as you rightly said, it is cellular, more number of cells they are accumulated in the interstitium. It is cellular phase. That means the prognosis is good. You can treat, you can decrease the cell with steroids. It will not go for fibrosis. If you say it is diffuse fibrosis, then the treatment will be resistant. These patients will be treatment resistant. It is end stage. If you say it is fibrocellular stage, then it is 50-50. So you can guide the clinician by looking at the histopathology. All of you agree with this?
Excuse me, sir.
Yes.
So even in the previous case, it was only the interstitial space that was affected.
Though
So
that's why
what?
these are called as interstitial pneumonias. All the big category, except for few misnomers that I'll tell you in the end slides. Why they're clubbed in interstitial pneumonia? I told you earlier that they are restrictive lung physiology. Radiologically and histopathologically, predominantly interstitium will be involved. But the diagnosis will only come after you examine the clinical, histological, and radiological multidisciplinary approach, which you should remember. Right? They are called as interstitial pneumonias because the pathology is in the interstitium. The significant pathology in all those diseases will be interstitium. Depending on these patterns and the observations, you classify this. Understood?
So what I meant to say was comparing this case, non-specific interstitial pneumonia with interstitial pulmonary fibrosis.
Yes.
In both the cases, isn't only the interstitial space affected?
Correct. You are right.
Then how do we differentiate that it's
That's what
non-specific case? Is it
I
because
told you.
of?
That's what I told you to remember three important things. Temporal heterogeneity, spatial heterogeneity, presence of fibroblastic plugs. These are the three important histological features for you to say that it is usual interstitial pneumonia. Number one, are you seeing any spatial heterogeneity? That means any uninvolved normal lung parenchyma in this picture? Yes or no?
No, no,
No. So that is
no.
out. Are you seeing any kind of a different, that is temporal heterogeneity in this lesion? That means some focus are showing a lot of fibrosis, some focus is normal, and some focus is showing initial inflammatory stage. Are you seeing that kind of a picture here?
No, all
No,
looks same.
And are you seeing any fibroblastic plugs where there is young proliferation of fibroblasts here? Are you?
No.
No. So when you don't see these pictures, that's what I tell you. Interstitium is the main thing that is involved, but those histological features are not seen. That's why I will not call this as in idiopathic pulmonary fibrosis. It goes in non-specific interstitial pneumonias. Understood this? These are the
Can you
important
show
things you
the
should observe. Yes.
can you show the fibroblastic foci again?
You want to see?
Okay.
I'll go back again. This is one fibroblastic foci. I'll show you. See, can you see this part? This whole part, these are young, loosely placed fibroblastic foci. I'll show you. I'll go back again. Sorry.
It's also kind of like part of spatial heterogeneity in the sense that
I'll show.
surrounded by
I'll show.
similarity
I'll
and
show. Can you see this picture?
yeah, right.
Yeah. See in the picture A, this is the pleura actually. Surgical lung biopsy, the topmost layer is the pleura. And when you see this fibrosis, can you see my arrow? Can you see my arrow?
Yes, I can.
So you just see,
Yeah.
I'll just trace the arrow. So this is all fibrotic area, all of you agree? It is extending
Yes.
till here. It is going like this.
Right.
It is coming. There is big chunk of fibrotic foci here. It is extending till here. This is the part of the bronchi. It may lead to traction bronchiectasis here. The fibrosis is here. Can you identify?
Yes.
And can you
So
see
it's
this
just
part? Can you see this part? Let
part
me finish. Let me finish. Can you see this part? There is fibroblastic foci at the end stage here. But what is happening here? This part of the lung is perfectly fine. These alveoli within the lesion is perfectly fine. These lesions, alveoli, they're perfectly fine. Did you understand?
right. Okay. So it's just a
Yeah, that's
it's
what.
just a
That's
consequence
why
of the
why the surgical lung biopsy is important in interstitial lung diseases. You have to see a large area. If you take a small biopsy, it is highly impossible for you to give a definitive diagnosis of interstitial lung diseases. All of you agree? You need to have a large biopsy. That's why VATS guided video assisted thoracoscopic surgical lung biopsy is required for a definitive diagnosis of interstitial lung diseases. You have to remember this. Why large lung biopsy? Because you need to see larger area. If you see only this part area, small biopsy, you cannot say whether there's a temporal heterogeneity or spatial heterogeneity. Understood? You need to say big. So that's all. This big biopsy is always required in this when you are evaluating interstitial lung diseases. Are there any doubt till now?
Excuse me, sir.
Yes.
In the non-specific case,
Yes.
is the increased cellularity due to cell infiltrates?
Due to?
Cell infiltrates.
Yes.
I mean,
See, one thing. Let me clear this. All interstitial pneumonia, when you have an initial thing, you will have cellular infiltration in the interstitium. That's full stop. They are classified as interstitial pneumonia because there is inflammatory cell infiltrate predominantly affecting the alveolar interstitium. Less involved is the other parts of the lung parenchyma. There is no doubt. Is it clarified with you?
yes, sir. Yes, sir.
Work. Depending on the pattern and histopathological changes, both on HRCT and microscopy, you have different patterns. This is all pattern based diagnosis. Okay. Depending on that, whether spatial, temporal heterogeneity, presence of fibroblastic plugs, you categorize it as the idiopathic pulmonary fibrosis. If it is uniform, if you don't see this kind of heterogeneity, you call it as non-specific interstitial pneumonia. That's what in the initially they said non-specific interstitial pneumonia is a waste basket type of diagnosis. First, when you get the slide, try to see this spatial temporal heterogeneity or fibroblastic plug just to confirm or to rule out idiopathic interstitial pneumonia or idiopathic pulmonary fibrosis. If you are not seeing this, label it as non-specific interstitial pneumonia. Did you understand?
Yes, sir.
Depending on further modification, further discussion, further observation, non-specific interstitial pneumonias can further be sub-categorized. That I will tell you in front. So this is main motto of interstitial pneumonia. All of you should think, see, for example, any tumor comes, my main motto is whether it is a cancer or non-cancer. That is different. The big classification is whether the patient is IPF or not. Final. To say IPF, you need to have these important features, either HRCT and also on microscopy. Understood? Okay.
Yes, sir.
Okay. So depending on non-specific interstitial pneumonia, see, I told you this. So you can, when the clinician is in a dilemma, when radiologists say that HRCT favors NSIP, that is non-specific interstitial pneumonia, even pathologists will say that this is non-specific interstitial pneumonia. The diagnosis, this multidisciplinary approach is full stop. But you still have an upper hand, histopathologist. You say that, see, I am seeing predominantly inflammatory cells. It is in the initial stage. You start treatment early, patient will respond normal. So it is not gone into fibrotic stage, or it is not gone into intermediate stage. If you see fibrotic stage, that means clinicians will think that even if I treat, the prognosis is bad when compared to initial cellular phase. Okay, so this NSIP again divided into cellular phase, fibrotic phase, or fibrocellular phase, which is intermediate. You still can guide the clinician or tell the clinician that this is further extra knowledge what I'm giving it to you. You please go ahead and treat the patient, follow up the patient fast. All of you understood? Okay.
Hello, sir. This is Subhashini.
Swaswini, yes.
Sir, in usual interstitial pneumonia, is it possible that with time progresses and disease progression, there won't be any spatial heterogeneity or temporal
Yes,
heterogeneity?
one
There
thing
will
you
be
should
diffuse
remember, the
fibrosis.
problem comes here is when you are evaluating any interstitial lung diseases in the end stage, where all of the interstitial lung diseases, if you don't take treatment at the early stage, all of them they'll end up in fibrotic stage, that is diffuse fibrotic lung diseases. So when you have a diffuse fibrotic
Okay.
lung diseases, it is not possible for the radiologist, clinician, or the pathologist to say what leads to diffuse pulmonary fibrosis, whether it is UIP, NSIP, etc., etc. You cannot make any differentiation. So all biopsies, one thing you should remember for UIP, I have not told this because it's an undergraduate class. You have to take 3 different biopsy from 3 different sites. When you take the HRCT scan, you have to take, the radiologist will mark this is the highly fibrotic area, this is a less fibrotic area, this is normal looking area. If you have to take biopsy from all those sites and evaluate, then your diagnostic accuracy will increase. Any doubts regarding this?
Okay, sir.
Hmm.
Yes, sir. Now clear, sir.
Yes, good. So this is inflammatory cells, all of you can see. So when you have, see this picture, even when it goes to fibrotic stage, NSIP going to fibrotic stage, you will see a lot of interstitial fibrosis. Can you see here? First patient, this part of the lung, almost 2/3 of the lung parenchyma, they're showing diffuse fibrosis. This is the adjacent lung parenchyma, which is still not involved in the disease process. If you see in higher magnification, the interstitium, all of the interstitium, they show a lot of fibroblastic proliferation. It is uniform. So when you see this kind of a picture, you call it as NSIP fibrotic stage. Okay, you will see less inflammation. If you see fibrosis and inflammatory cells, you call it as fibrocellular stage. This is about, so this is again fibrotic stage of NSIP.
Excuse me, sir.
Yes.
On the last slide,
Yes.
if you look at the left image, can we call that to be a spatial heterogeneity?
No.
Like on the left side, the image.
You are exactly right. So spatial heterogeneity, you call it as, this is the disease progressive front. After this, the lung parenchyma is uninvolved in NSIP. But in UIP, the spatial heterogeneity, you have to see uninvolved lung parenchyma in between the lesion, not at the edge of the lesion. This is the uninvolved and involved lung parenchyma in NSIP. But there is no uninvolved lung parenchyma within the lesion, disease lesion. That is very important. Understood? You have
Yes.
any? Okay, that is called spatial heterogeneity. You have to see uninvolved lung parenchyma in between. Even I showed you the gross of IPF, HRCT of IPF, and you are seeing uninvolved lung parenchyma lying in between the fibrotic lesion. So that is important. If it is uniform, it is NSIP. Okay, this is about NSIP. There is one entity is called as cryptogenic organizing pneumonia. The radiology and the pathology is typical like organizing pneumonia pattern. You know the pneumonia, bacterial pneumonia, lobar pneumonia classification, subcategorization. That is, what are the four subcategorization of lobar pneumonia? Stage of congestion, gray hepatization, okay, red hepatization, gray hepatization, resolution. When the stage of resolution, how do you say it is load of organizing patterns? So they will say fibroblastic plug or Masson bodies usually VK that will be present within the alveolar lumen. This is only some part of the lung parenchyma is involved. You can see prominent air bronchogram. The radiologist will say it is consolidation. So restrictive physiology, consolidative pattern on HRCT with presence of air bronchogram. On histology, you will see fibroblastic. I will not. These are Masson bodies. One thing you should remember: fibroblastic plug. If I say it indicates that you are describing IPF or UPF. If I say Masson bodies, these are also fibroblastic proliferation. They are projecting into the alveolar lumen. Can you see this alveoli? They are projecting into the alveolar lumen. That means there is some, there was some pathology in the lung parenchyma in the alveoli that has been organizing. So this is called as organizing pneumonia. The presence of Masson bodies, fibroblastic plugs within the alveolar lumen. Okay, this when you see under histopathology, we call it as organizing pneumonia like pattern. So we'll say the clinician that it is organizing pneumonia like pattern. He will evaluate all the bacterial, fungal, autoimmune causes of organizing pneumonia. If all comes negative, then it will go for, it will be labeled as cryptogenic organizing pneumonia. I totally agree that some of the interstitial lung diseases, they are still misnomer. You do see some kind of inflammation, but it is not predominantly interstitial pneumonia pattern. It is classified as interstitial pneumonia because when large part of the lung is involved, it shows restrictive lung physiology. Okay, that you should remember. So there are one more entity, organizing pneumonia and bronchiolitis organizing pneumonia. Bronchiolitis obliterans organizing pneumonia. BOOP, that is called BOOP. So when you see Masson bodies within the alveolar lumen, we call it as organizing pneumonia. Similar kind of Masson bodies, if they are causing or obstruction in the terminal bronchiolar lumen, causing obstruction, we call it as bronchiolitis obliterans. It is obliterating the bronchial lumen and also showing adjacent lung parenchyma of organizing pneumonia. Then we call it as BOOP, bronchiolitis obliterans organizing pneumonia. Can you see this bronchiole? There is peribronchial inflammation. Okay, here, and I don't have this picture. And these fibroblastic plaques, they are also present in the bronchial terminal bronchiolar lumen. Bronchiolitis obliterans organizing pneumonia. So this is very important. Okay, this is classified under restrictive lung, interstitial lung diseases because it shows restrictive lung physiology. It is some kind of a misnomer entity that you should remember. And diffuse alveolar damage. So all of you know that acute interstitial pneumonia, we call it as clinically. It also presents with, nowadays you are more familiar because of corona pandemic. Most of the patients died maybe because of diffuse alveolar damage. One thing you should remember, diffuse alveolar damage is the histological term. Histopathologist will label this as diffuse alveolar damage, but the same patient, when you go to clinicians will label it as clinical entity for the same diffuse alveolar damage is acute interstitial pneumonia. Okay, both are same, but clinicians will say acute interstitial pneumonia and pathologists will say it is diffuse alveolar damage. So when you see in microscope, HRCT scan, The whole of the lung diffusely involved with ground-like opacification, alveolar exudates, and radiologists can better describe these entities. But when you see and histopathology, the most important feature that you see is diffuse damage to the alveolar lumen, and the lumen is shows a eosinophilic hyaline-like material. All of you can see this. This is called as hyaline membrane. Similar histopathology is also seen in neonatal distress syndrome, hyaline membrane disease. And if you see in adults, it is diffuse alveolar damage secondary to any other diseases, either bacteria, septic shock, drugs, whatever may be. Along with that, you will see there is interstitial edema, lot of inflammation, and eosinophilic hyaline-like membrane, which is lining the alveolar wall. Why these patients will die? This is corona pandemic. Lung is totally involved. CORAD score more. The patient died. Oxygen saturation is not improving. Mainly because when you have a predominant alveolar wall damage, this plastic-like material which coats the alveolar lumen and prevents the gaseous exchange. When it is extensive, even if you do nasal oxygen, high pressure oxygen, oxygen will not be diffused here. The oxygen concentration in the blood will not increase. The patient will ultimately die due to multi-organ failure, hypoxic kind of an injury to all the organs. All of you understood this? Yes?
Yes, sir.
Yes. So this is, can you see this hyaline, eosinophilic hyaline-like membrane? And it is completely coating the inner alveolar wall. This is very important. It is the diagnostic feature for the histopathologist to say that it is a diffuse alveolar damage. Okay, that term, whenever you see the histopathology report, whenever in future when you go to clinical, diffuse alveolar damage, that means it is nothing but clinically acute interstitial pneumonia, or it is a type of hyaline membrane disease. You should remember these terminologies. Okay, that I will not tell you this. Then there are,
Physicians all like
yes,
they make a difference between ARDS, ALI, and AIP.
see, I told you the entity is same. Entity is same. The disease is same. Clinicians will say it is acute interstitial pneumonia. Pathologist will say diffuse alveolar damage. Saying that the pathophysiological process causing diffuse damage to the alveolar lumen. Okay, so this is acute ARDS, acute respiratory distress syndrome. But when you know the cause, you call it as ARDS. Even after excluding all the possible causes of ARDS, if you don't know the etiology, then they label it as acute interstitial pneumonia. Do you understand? For histopathologist, the terminology is same. It is diffuse alveolar damage. If clinicians says that the patient is a case of ARDS, this is the cause, the diagnosis will be acute respiratory distress syndrome. Even after evaluating all the known causes of ARDS, I cannot find any cause, unknown cause or idiopathic cause, then they will label it as acute interstitial pneumonia. Is it clear?
Yeah, right.
Yes.
And what about the term like acute lung injury?
What?
Acute lung injury is also a term
Same,
I've
almost
heard.
same. Acute lung injury, everything is same. Yeah, everything is same. Clinical presentation will be same. Histopathologic observation will be same. Depending on whether you can identify the cause, identify the etiology or not, the terminologies are different. Okay. Acute lung injury is a pathophysiological mechanism. Acute respiratory distress syndrome, what clinicians they says, because he knows the etiology. If he doesn't know etiology, then it will become acute interstitial pneumonia. For pathologist, whatever the entity, our diagnosis will be diffuse alveolar damage. All of you understood? Yes.
Yes, sir.
Okay. And there are two important interstitial lung diseases that all of you should know. These are exclusively seen in heavy smokers. One is respiratory bronchiolitis associated interstitial pneumonia and desquamative interstitial pneumonia. These are typically associated with heavy smokers. If you stop smoking, it will revert back to normal. If you don't stop, it will progress. Okay. Respiratory bronchiolitis, pneumonia, how it shows on histopathology, you will see a pigmented or smoky macrophages, smoke laden macrophages within the bronchiolar lumen. Then you call it as bronchial this thing what respiratory bronchiolitis associated ILD. But it is not typical case of ILD. What I mentioned, it is not typically you will not see any significant inflammation in the interstitium, but it is showing restrictive lung physiology. They are classified under interstitial lung diseases. It is again misnomer. So it is the initial stage. In heavy smoker, initially the smoke laden macrophages will be accumulated in the terminal bronchioles or respiratory bronchioles. We call it as bronchiolitis, interstitial pneumonia. In later stages, the similar pigment laden macrophages will be present throughout the alveolar lumen. Then we call it as desquamative interstitial lung diseases. Both are same. Respiratory interstitial lung disease is in the early stage. If it continues, it will become desquamative interstitial pneumonia. Again, desquamative interstitial pneumonia is misnomer. Initially, they thought these are the epithelial cells which are shed from the alveolar wall, alveolar epithelial cells. That's what they initially they told, mentioned the term desquamative. It is not true. These are nothing but alveolar macrophages. They are not shedding of any epithelial cells of the alveolar lining epithelium. Did you understand? But the terminology is still retained. Any doubts in this? Fine. So lastly, these are the main important interstitial pneumonias, and depending on the pathology, and again they have one more entity called as lymphoid interstitial pneumonia, where you see lot of lymphoid infiltration. Can you see this? This is first two pictures. They are all hemocytin laden macrophages. This is the iron stain. The blue color gives the hemocytin deposition. Various pigments you see in case of smokers, and the down picture it shows lymphoid aggregates in the interstitium or peribronchial region. If it is prominent, we call it as lymphoid interstitial pneumonia. It is again classified under interstitial pneumonias, and this kind of a pattern it is also seen in many autoimmune related connective tissue disorders where the lung is secondarily involved. So for undergraduate purpose, these are more important, and other things hypersensitive pneumonitis, occupational lung diseases, and also other connective tissue diseases, hypersensitivity, all it comes under interstitial pneumonia. They are not much of important to discuss at this stage. You can read that. So any doubts till now in the main category of interstitial pneumonias which I have told you, mentioned now? If you know this, it's more than enough. I agree that it is very important. Interstitial lung pneumonias, it's very big chapter, and these are the main histological, radiological, and clinical features all of you should remember at undergraduate level. Any doubts till now?
Excuse me, sir.
Yes.
So when there is difference between clinical radiological diagnosis made, we go for pathological studies.
You are right. You are right.
So what? So will that pathological study be the confirmatory one, or will it be just
Yes.
consideration
See,
for the final diagnosis?
Yes. What I told you, it is not same for each and every cases. Each and every case where we get biopsy is a problematic case. Clinicians will sit, he will see the disease progression, the disease predominantly. See, NSIP or non-specific interstitial pneumonia usually seen in case of fourth decade. It starts appearing on fourth, 1 decade early. But IPF usually seen, patient will be fine. By the time he present will be in the end of fifth decade, sixth decade. The clinicians will say the clinical progression according to my observation, it favors IPF, not I will keep differential as IPF in the first differential, next NSIP. It goes to radiology. Radiologists will say, for me, I still keep IPF, it's not classical, but still I keep IPF depending on the pattern as a first possibility and NSIP as a second possibility. And histopathologically, I say that I am seeing this temporal spatial heterogeneity with fibroblastic plug. I feel according to histopathology, I still keep a UPF, IPF as a Usual interstitial pneumonia is the first category. The patient will be treated as usual IPF. One thing, if there is dilemma, radiologist is not sure it is IPF or NACP, it can be this, it can be this, and pathologist will say I am not finding any UPF histopathology, I am finding more features in favor of NSIP. It will be treated and observed as NSIP. If he responds, after follow up, it is good. If it does not follow up, again they will see the HRCT scan, whether how the disease is progressing. Again they do biopsy, again will observe. And the second stage, if you say that initially it was NSIP like pattern, but I am seeing UPF like features, then that will be categorized as UPF. Any doubt till now? Did I clarify your doubts?
Yes, sir. Yes, sir.
Yes,
Thank you,
that's
sir.
important. Good, great. All of you go back and read about this. Any doubts regarding this, you can come and meet me in my chamber whenever you are free. I'll be here in the department. So all of you are free to, but thing is, you guys have to involve yourself in all the academics. And I have been observed, and even our HOD, Dr. Venkatayar also, he mentioned, we give a lot of educational supplements. We are always there to help you, but we need a lot of feedback from you guys, inputs, and uh, be active. And the attendance is very less, I don't know why. And you guys, because you're sitting at home and you have to improve your attendance, that's very important. It is a huge loss for students. And class representative, who are you are, and Bansal, who is the class CR? Baumik. So ask Baumik to meet me. Then Mohit, you just meet me. So whenever you're free, we'll just have a discussions. You tell other residents that they should be present online, unless until it is they are affected with COVID, they have important work. It's fine. Attendance is not mandatory according to the academic, but we are not bothered about attendance. We are bothered about exchange of, and we somehow want you to understand the pathology, so that when you go to next step, the clinical, you will have a lot of knowledge, and you have a lot of, you can think and collaborate yourself, you can think what are the disease process, what can be done. This kind of interaction we have to develop. Okay, so anyone who is having any doubt in any of the specialty, we are always there in the department. So all of you can at any time to discuss their doubts. Okay, so thank you very much. So all of you go back and rebrush your memories regarding uh, lung, cardiovascular, and not only lung and cardiovascular, all previously covered topics, right?
Yes, sir. Sure, sir.
Yeah, good, great. So your next session will start in another 10 minutes. So you guys take a break and come back and join. Dr. Seema will take the class. Okay. So take care. Bye bye. Fine.